Okay, so the topic of today is a little bit strange because it's talking about intracranial hypertension and cerebral venous outflow. So in order to understand that, there are a lot of physiopathology, pathophysiology, and physics principles, and they rely on a number of laws and doctrines and hypotheses and a lot of Greek terms. So I figured out that it's too early in the day to do that, and therefore we're going to keep it on the simple side. So everybody has gone traveling. I know from firsthand, and every time you leave your house, everything is neatly packed, everything is nice. Your luggage, you stroll around the airport. The only point is that when at the end of vacation you try to pack, you are in a different situation and your luggage is overflowing with stuff. You sit on it, you push on it, and it's not the same neat experience. So the same can happen to the skull, to the intracranial compartment. And so let's try to go through the steps in order to understand what's going on. So essentially the skull is a box, or better, is a box with a hole at the base of it. And this hole is called the foramen magnum, which is a Latin term to say big hole. But it sounds better when you say things in Latin in medicine. So this is shown from the bottom and it's marked in green. And the foramen magnum is something that you're going to keep hearing over and over during this conference because it's the site where the tonsil herniation of the Chiari malformation occurs. Now, like in the movie Seven, what's in the box? And in the box, there are a lot of things going on. So in the beginning, it can look a little bit confusing, but like baking a cake, everything boils down to the basic ingredients. So what are the basic ingredients in this case? One is the brain. One is the cerebrospinal fluid, again, something you're going to be very familiar and become very familiar during this conference. And the third one is the blood. And the blood goes inside the skull with arteries, comes out of the skull with veins, and then there are capillaries in between in order to push nutrients and oxygen into the brain, and then to remove the products of metabolism, practically the garbage, taking the garbage out. Now, the brain starts on a certain volume, and then it grows and it reaches a sort of a peak volume at the end of adolescence, and then from that point on, it's just a progressive loss. It is like being a trust fund baby, and you do not add anything in the bank with wise investments or additional work, and practically you have an erosion of your capital over time. So how does the brain can change? The brain can change because tissue inside it goes out of control, in this case a tumor, or can change in the opposite direction by shrinking progressively with aging. Cerebrospinal fluid compartment has a fixed amount of cerebrospinal fluid volume within the system. Most of it is located inside the spine. Is a very small amount compared to all the rest, but sometimes again can go out of control and can generate pathologies such as the hydrocephalus. So the venous system is quite complicated. There are some major highways inside the skull, venous highway inside the skull, which are called the dural sinuses. Quite complex, but like a major drainage system converges towards two major pipes, which are the internal jugular veins, which come out from the base of the skull and go towards the heart. Again, these two major pipes convey about 85% to the venous blood. So practically these two jugular veins, they're like a garden hose, and everything goes nice and dandy until sometimes some people steps on the garden hose. And if that happens, your effort of watering your lawn becomes problematic. It's the same as a traffic jam on the highway where there is an accident and many lanes are occluded. Incidentally, the biggest traffic jam ever lasted for 11 days in China. It was 16 miles long and involved several million people. Now, what happens in this case is something which is very familiar to these two gentlemen, one of which was the president of the local Lutheran church. Unfortunately, these are not very respectable people because they're respectively the BTK strangler and the Boston strangler. So what happens when you strangle somebody? Many things, and you can crush the windpipe, you compromise the arterial circulation, but why do you become purple? You become purple because the blood cannot leave the brain anymore, and therefore you're compressing the jugular veins. That leads to a swelling of the brain, which is not a good thing, provided that your skull is a closed box, and that leads to increased intracranial pressure simply by pushing on the jugular veins. Now, there are a number of diagnostic tests, being serious for a second, that we usually do in order to figure out these things. And from basic imaging like CAT scan, MRI, CNMRI, MR myelogram, and to things which are a little bit more involved like CT angiogram, CT myelogram, and then up and up in tests which are more and more invasive, like angiogram, venogram, manometrics, lumbar puncture with cerebrospinal fluid removal, and intracranial pressure monitoring. This is an example of a CT angiogram. Practically, it's a CT with three-dimensional reconstructions in which we can visualize arteries and veins passing by. We can color code them in the process, like color coding for dummies. And we can do a lumbar puncture, insert a needle, and remove some fluid, and to see what happens to the symptoms. And then we can also insert a probe inside the head and measure the pressure inside the skull itself. By doing that, we can also add positional testing by putting patients in different positions, and we can express the data in centimeters of water, or in this case, millimeters of mercury. And in order to make it simple again, we can express the data as normal, green, or they're not so great, yellow, or danger, like is red. 28 millimeters of mercury in centimeters of water is a hell of a lot. Now, measuring the intracranial pressure is important sometimes because in 1 out of 7 cases that we see here, the symptoms are not exactly predictive of what we actually measuring later. So in 1 out of 7 cases, the intracranial pressure monitoring show us that instead of having high pressure, sometimes people have low pressure, even if the symptoms are suggestive of the first. The venogram with manometric measurements is a little bit more more complex. That's why I show it here. And it's practically a catheter coming from the groin, floated towards the skull. The radiologist inserts some contrast, and we get an idea about the shape and the volume and the course of the internal jugular veins and the sinuses inside the skull. Adding a test called manometrics, we can measure the pressure, besides the flow, we can measure the pressure above in certain key points in order to evaluate, say, if certain strictures are interfering a lot or a little with the regional traffic. So these are more sophisticated way to do it. Now, there are some pathologies which can affect the venous outflow, which can represent the equivalent of the foot over the garden hose. Now, this is a sort of a summary. You can have a stenosis of the dural sinuses. You can have a stenosis of the jugular foramen, which is the hole through which the jugulars come out from the skull. You can have a stenosis of the internal jugular veins throughout their course through the neck. And it's important also to evaluate if the patient has a collateral venous circulation. Collateral venous circulation is when, imagine that you have a highway, accident on the highway, there's a big traffic jam. What's going to be your first instinct is going to be to take the first exit and go on the side streets. So there are a lot of veins, which are very small in the area, which can be used as side streets. In that case, when they become overwhelmed, they become bigger and bigger to become sort of like big varicose veins. And they can be the sign of, they can be kind of the indirect sign, supplementary sign of problems with the venous circulation within the venous system, especially within the internal jugular veins. Now, There is also another recent concept, which is that one of the short circuit between venous plexus and the lymphatics at the base of the skull. This is a fairly recent series of articles coming from two different groups, one which was located at NIH, which shows a very intense functional interaction between the venous system of the brain and the lymphatics. Now, it's important because the brain allegedly has no lymphatics, is the only organ in the body without lymphatics. Lymphatics are good about draining extra fluid, but a lymphatic system has been found at the base of the skull, just slightly outside, and an interconnection between the venous system inside the skull and this lymphatic system has been recently demonstrated, opening a lot of new understanding. But besides that, we go back to basics. I lost my ears, so now I'm back with my ears. So back to the major venous highways inside the skull. These are the dural sinuses. The dural sinuses have a complex configuration. Practically all the minor veins coming from the brain, they converge to these highways. And they have different names, they have different locations. The important thing to understand is that all of these converge towards the base, towards the origin of the internal jugular vein. Now, there are some locations which are more prone than others to be problematic, and one of which is called the transverse sinus, the other one is the sigmoid sinus. And the sagittal sinus is actually more important, but when that is compromised, you have a lot of other problems. So it is more serious. The most current locations where the interventional neuroradiologists find problems in patients with increased intracranial pressure who are not super sick are the transverse sinuses, especially the right one. From the inside the skull to the outside of the skull, there is the internal jugular vein goes through a sort of a tunnel, and within this tunnel you can have problems. Either the tunnel closes on the jugular, like in craniosynostosis, or you can have tumors within that tunnel that are kind of eating space and pushing the jugular on one side. Then lower down you have the jugular veins and a bunch of other veins which are functionally connected to it, but this is a kind of a known entity, known concept, so I'm not going to waste a lot of time on it. One thing which is interesting is that there are some extra structures in the area, one of which is the stelloid process. This is a hypertrophic stelloid process. This is a stelloid process which is much longer and much thicker than what it should be. And it happens to pass by the jugular vein. So sometimes this can become a problem. It can push a nudge and an elbow into the jugular, therefore creating the foot on the hose scenario. And these are the stelloids seen from the front after removing the mandible. Another part of the anatomy, which can be sometimes problematic, is the very lateral edge of the first vertebra, which is called transverse process, or other people call it the tubercle, is indicated by that red arrow. So the jugular vein passes nearby, but sometimes it can be elbowed pretty hard by this bone. And this is an example of it. These are internal jugular vein on the left is reduced to a ribbon, on the right is elbowed, and there is a lot of collateral circulation. This is the detail. And this shows how that lateral elbow of C1 can dig inside the jugular vein. So what happens, the traffic goes into the side street and you have all those varicose veins nearby. Sometimes it can be between a rock and a hard place, because if you're really lucky, you end up having a big styloid process on one side and the big tubercle on the other side of C1, and the jugular vein gets compressed to almost nothing. So what can we do for that? We can remove cerebrospinal fluid, you can shunt cerebrospinal fluid, you can stent the areas of the transverse sinuses which are compressed, or we can remove the choke points around the jugulars. Now, in order to add something, the jugular can also be compressed dynamically, so on and off, by muscles passing nearby, one of which is the sternocleidomastoid and the other one is the omohyoid. But, you know, all you have to do is just to move your neck a little bit and that compression disappears. So it's less frequent. You need a surgical intervention for that muscle dynamic problem. But you can cut that muscle or strip it away in order to create more space for the jugular vein. So lumbar puncture, again, you stick a needle in the back, you can remove some fluid. Hopefully it's a one-shot deal or intermittent shot deal once a month. And removing 30 cc's of fluid it's a pretty large removal compared to the overall normal amount of CSF, which is about 150 cc's. So what's the concept? The concept is if you stick a needle, measure the pressure is high, and after removal of fluid, a lot of symptoms, and especially a pressure headache, improve. That means we found the cause, and we have a cause and effect relationship which is demonstrated. Now, the problem with the lumbar puncture is that so much you can puncture the dura once a month before the dura becomes a colander. So another of the strategies to do a VP shunt, which is a shunt from the brain, from the CSF system on the brain to the abdomen or the dura or other places, or a lumbar peritoneal shunt, or to put an Ommaya with intermittent drainage. Now, all these things hit the wall in a category of thing called idiopathic intracranial hypertension because the cerebrospinal fluid system is kind of narrow, and most of the problem is not into the CSF, but is from the venous congestion, as we've seen before. So in these patients, what the pay is for is to go and detect where the problem is and to address it. So in this case, there is a stricture of the vein that you can see on the left side of the picture. They put the catheter, they measure, they take pictures, they measure the pressures, and then finally they put the stent if it is indicated once certain qualifying criteria are passed. And you see that over there is a re-expansion. So from down to 2 lanes on the highway, you go back to full-blown 5 lanes throughout the entire transverse sinus, and you're back in business. The right transverse sinus, for a different kind of set of anatomic reasons and embryological reasons, is the most common offender. So these are pictures on the angiogram and on the 3D CT of how a stent is placed, and most of the time the stent is placed through the transverse sinus, through the stenosis, and sometimes into the first part of the sigmoid sinus, which is a continuation. But if the problems are affecting the jugular veins between the rock and a hard place scenario, at that point you're going to have to cut off those pieces of bone. One is the styloid. If the styloid is on the way of the jugular and is creating problems, you can take it off. You can go through different approaches, inside the mouth or outside. I prefer the neck approach, and you can cut it all the way to the base of the scalp. And obviously, there is a decision making for styloidectomy. I'm not going to bore you, but this just shows how unusual is the styloidectomy in our practice. Out of 2003 patients, we found that 304 over the course of several years had styloid hypertrophy, and only 38 of these patients ended up having a surgery. Again, these were patients who were already screened for styloid hypertrophy-related symptoms. Now, the other thing you can do is to remove that elbow compression from the first vertebra, and these you can see the jugular vein on the left side of the screen, which is elbowed up, and it looks like a little coma or a little hat on top of the bone. And this is how, after removal of that bone, how that jugular vein has expanded maximally. And this is another example, and the arrows on the right and the left in the middle of all that bunch are showing the jugular veins and how much they decompress before and after. So what's the wrapping up? The outflow of the venous blood from the brain to the heart has to be as close as ideal as possible in order not to create problems. And if there is the foot on the garden hose scenario, that can create brain swelling and increase of intracranial pressure. So this has to be in mind whenever there are situations, or sometimes even when somebody has a Chiari malformation that gets operated on, looks good on the postoperative anatomy, but the patient has still pressure headaches and Valsalva, aggravated by Valsalva maneuvers. So looking at the direction of CSF outflow can be helpful. So there is diagnostic protocol, there is a decision-making tree that I did not, with selection criteria and qualifying criteria that I did not describe here for the sake of brevity, which have to lead to qualifying criteria. So if you are green, nothing. If you're red, yes. And the expert is going to decide when to do it and when not to do it in the shade of gray in between. Now, the long-term outcome is something that is still an open problem for the specific of the stenting. The stenting of the transverse sinuses have been around for, at this point, about 15 years. They were very promising in the beginning, and then, like everything that you start following on time, show over time some problems of post-stent stenosis and reocclusions and complications related. But again, overall, even if they are less spectacular as initially advertised, there's still a big improvement in not having a good transverse sinus at all. On the other hand, the stenting of the jugular veins has been recently shown as being not as good as the stenting procedures for the transverse sinus. For the internal jugular vein, whenever there is a compression, it is better to do a surgical decompression rather than a stenting, because the stenting, as per recent articles, have a much lower success rate and a much higher complication rate. So what's the wrapping it up? What's important thing is problems with the venous drainage from the skull to the heart can lead to elevated intracranial pressure, leading to symptoms which boil down to, I have a big headache, I feel my headache is exploding, and every time I'm straining, I feel worse. Thank you very much.
Thank you, Paolo.
Hey, Paolo, it's Brian DeLohi. Thanks for the talk. I'm going to open up for questions right here, okay? So anyone?
Hi there, my name is Wendy. I'm asking a question about the stenting, and you said that maybe that is not as good as you thought or wanted it to be in the beginning. Is there a way that you take those stents out and can re-put them in, or does that just depend on the stenosis and what happens with it while it's in there?
Okay, it is like the first reaction is do not take the criticism in a black and white term. I'm not saying that the stents are bad. They're just the stents are not as fantastic as initially perceived, but the overall balance of the stenting experience for transverse sinuses and intracranial sinuses is very, very, very good. That said, there is a growing experience in the interventional neuroradiology community, which is specialized in the sinus stenting, about what to do in the LD afterwards. So I don't want to sound like amateur hour. That question should be thrown to them. But the reality is that they have been developing different strategies, and right now they're testing about what to do, what not to do. About the retrieval, I do not I didn't see many. Usually what I see about rescuing of situations is tandem stenting or, maneuvers inside the stent in order to make it patent again. But the biggest problem for the stenting is the post-stenting stenosis. So practically, you put a stent, and then over time, several years later, the part immediately after the end of the stent becomes narrowed. So at that point, they put another stent in series to re-expand that area. So I have not seen yet one of my colleagues in neuroradiologists removing a stent and putting a new one, but I'm not ruling out that that's been happening.
Other questions? Hey, Paolo, I have a quick question. The decision tree for IAH and how to treat it varies significantly, right, from every institution, it seems like. I mean, I think it's more varied than Chiari and probably any condition I know. What's because we don't really understand you talked about the pathophysiology, like the cause of it, but it's still somewhat unclear, right? Like, for example, why is it more common in women than men? Do you have thoughts on that? Or why do you think, obviously, in some patients, weight loss does seem to help IAH? What are your thoughts on that?
You opened three can of worms. The first one, I'm going to start from the last one because the least controversial. The weight loss, the classic original textbook, patient for model patient for idiopathic intracranial hypertension, which translated in from Greek to English for the people who do not know means I have no idea why you have increased pressure in your head. That's what idiopathic means. That's the advantage of a classic education that I had. The classic patient was, 40, fat, female, and parentheses black. So there were these big women, and they were having high pressure, and then you were doing something for their weight, and their headache improved. The point is that when you have a very, not for you, but for the people in the audience, when you have a very big amount of fat in your belly, that compresses your inferior vena cava, and that has a effect over the venous plexus, which is surrounding the spinal cord and the dura of the spinal cord, and that has a direct repercussion on the cerebrospinal fluid, and that leads the pressure up. So in these patients, losing weight is the first thing to do. Now, the other thing is why female? From my experience, I suffer of something which is a specific viewpoint. The majority of the patients that I see, simply because the patients go wherever they feel that it's kind of a referral bias. I see a lot of patients with connective tissue disorders, and in patients with connective tissue disorders, there is a 9-to-1 prevalence of women to men. Now, that is kind of nonsensical because the distribution of connective tissue disorder genetics is autosomal dominant, which means there should be 50% transmission, but there is obviously a hormonal factor for the symptomatic conversion. So at that point, that becomes a 9-to-1 if you're a female. I do not know what is the incidence of venous outflow problems in the non-connective tissue disorder population. So about that, I'm completely blind. So that's why I have a referral bias from affecting my visual. But, for example, the incidence of styloid hypertrophy in the patient with connective tissue disorder is 4 to 5 times higher than the non-connective tissue disorder population. And the prevalence of symptomatic conversion of people with styloid hypertrophy in the patients with EDS and connective tissue disorder is 10 times higher than what's reported in the normal population. There is also an overlap between Chiari 1 malformation and connective tissue disorder that people at Duke have explored for a number of years. And the rough estimate is that maybe as much as one Chiari patient in 5 having associated connective tissue disorders. So, and now we're coming in the quagmire of too much information, and you get confused and do not look what to say. So the only thing I can answer to you is there are a lot of things that we can answer as a knee-jerk reaction, but I agree with you. The reason why the idiopathic intracranial hypertension problem is complex, and why every different institution has their own diagnostic and therapeutic decision tree. It's evident, and also depends also on the referral bias system. For example, people who are seeing mostly subjects who are morbidly obese, obviously they're going to have those patients with that particular pathophysiology set going to them rather than coming to me, because I'm going to look at them and I'm going to say, eat less cheese, eat less cookies, rather than doing something more, more scientific.
Other questions? If not, we can move on. But
hey, it's Saul Wilson here from Neurosurgery in Iowa City. A question on how you follow those patients now that you have 15 years of results with frequency of imaging and medical management, and what changes over the course of time with that.
Okay, I'm lucky because the majority of the patients who are coming here, since they're a little bit more complex because of the connective tissue disorder angle, they're very eager to undergo anything in terms of invasive diagnostic testing I'm throwing at them. So I have a big amount of intracranial pressure measurements before and after surgical decompressions. We have plenty of venograms with manometrics before and after. Now, this opens another door, which is that of what happens in many patients, which is more complex than just your jugular vein is occluded or your transverse sinus is stenotic, therefore you have a high pressure, and therefore we solve that and everything is done. The reality is that in many patients, there is something which can be defined as the roller coaster syndrome, which is a series of pathological attempts of the body to compensate for high intracranial pressure. So everybody remembers it's like a teapot. You put the teapot and the water starts boiling inside, and all of a sudden the valve opens and the steam comes out. So in many situations, and especially for the patient I see every day, which is connective tissue disorder, when if the dura is stretchy and if the pressure goes up, the first thing that the body is going to try to do is to stretch the dura in specific stressing points, which are for example, at the origin of the nerve root sleeve. That creates some little blebs which periodically can and will pop open, creating some micro leaks that then compensate themselves. So you're going to have a patient who belongs to high pressure territory because of their venous compression, the pop leak, and all of a sudden their headache changes and is not anymore aggravated by Valsalva, but aggravated by standing sitting up. Then all of a sudden, gradually over time, either because Mother Nature repairs it or because they get a blood patch, because somebody recognizes it, the pressure drifts back up, passing through a period of normality, and the patient is happy without any headache. It goes back up to high pressure territory again, and again they feel that the head is exploding, and every time that they go to the bathroom for push for number 2, they're miserable. So they can also have other situations, but so the issue is where in this roller coaster pattern you see the patient. So I had patients that follows over time that were confused in the beginning, and then after a certain amount of intracranial pressure studies, I figure out, and adding CT myelogram and venogram I was able to rebuild the scene of the crime and to understand what happened. Now, this pattern of roller coaster is actually more frequent than initially advertised. And in all this process of intracranial pressure, strange dynamics, things are kind of changing very, very fast, especially because of people like the people at Cedars-Sinai who are kind of working over and over on it, just with a kind of obsessive focus. For example, there was one pattern of cerebral spinal fluid leakage in the past, which was considered to be very rare, which is the CSF to venous fistula. Was considered to be very rare, like below 3% cantinodity, and now is estimated to be about 30% of present in 30% of the people diagnosed with intracranial hypertension. So there is more and more interest in these things. So answering your question, and again, I'm long-winded, I apologize. Yes, we have a lot of information, and part of the information is to try to crack the riddle of the individual patient. And the second one is I like to accumulate a lot of, especially invasive testing information, in order to look at the larger picture, in order to provide some scientific contribution that we're currently writing. For example, a lot of the places that they're dealing with the intracranial hypotension, they never put, they just assume that the patient with intracranial hypotension on the grounds of the symptomatic presentation alone without taking a measurement. And there's a lot of assumption over there. And the same, it is less for intracranial hypertension, but there are less data points of invasive testing in the studies out there that we would like to see.
Great, thanks,
the
Paolo.
bottom line is I prefer to measure more than measure less.
Thanks, Paolo. All right. No other questions. Well, thank you, Paolo, for joining us. Appreciate it.
Thank you very much. It was an honor to be here.
Thank you.